Okay, good afternoon, everyone, and a very warm welcome. Thank you very much for joining us at the Spotlight event on supporting health system resilience through the Bangkok Principles. I would like to begin by acknowledging the traditional owners of the land on which we meet, the Tur Abu, the Yug-Era and the Yug-Era peoples, and I would like to pay our respects to their elders, past and present. I would like to extend that respect to all Aboriginal and Indigenous cultures in the Asia-Pacific region. Friends and colleagues and participants, in our session today, I think we are all very much conscious of the fact that as the pandemic evolved, it also converged with a changing climate and a time of geopolitical uncertainty. And so these multi-hazard risks have put unprecedented strain on many systems around the world, but notably the health systems. And so in this session, the spotlight is on how health and DRR communities can effectively work together to support the health community to enhance health system resilience. We will also look at how the health community can support the operationalization of the Bangkok Principles and the health emergency and disaster risk management framework. And this includes integrating emergency and disaster risk considerations into national and sub-national health strategies, as well as the primary, secondary, and tertiary healthcare and related services. So we have just under 60 minutes for this session. And I'm very pleased to inform you we have a distinguished panel before us who are going to share with us their insights, their knowledge, and their experience. So on my left is Kun Panapa Nan, and Kun Panapa is the director of the International Cooperation section of the Research and International Cooperation Bureau under the Department of Disaster Mitigation and Prevention of the Royal Thai Government. She's been with the department for 14 years, and she has also worked with the Office of the Secretariat for the Ministry of the Interior and the Thai Community Development Center in Los Angeles. And during the big floods in 2011 in Thailand, Kun Panapa served as the Foreign Relations Coordinator at the National Emergency Operations Center. And then online, we also have Professor Emily Ying Yang Chan. Professor Emily is a clinical humanitarian doctor and a global academic expert in public health and humanitarian medicine. And she serves as professor and assistant dean at the Faculty of Medicine of the Chinese University of Hong Kong. And among the many roles that Professor Chan has, she's also the co-chairperson of two WHO groups. One is a thematic platform for health emergency and DRR, and the other is the Research Roadmap Social Science Working Group. And Professor Chan also has experience as a frontline emergency relief practitioner. And then on my left, next to Kun Panapa, is Dr. Nilton do Carmo da Silva. Dr. da Silva is an orthopedic consultant, and he currently works in the Timor-Leste Ministry of Health as the National Director of Hospital Services and Emergencies. He's also a board member of the Timor-Leste Red Cross. And during COVID-19, he played a critical role as the national coordinator for case management, and he was very heavily involved in the Integrated Crisis Management Center. So let us perhaps start off by just giving everybody a warm welcome and looking forward to our discussions and an interactive session. So I'd like to, well, before I start with the panelists, I'd like to also encourage everyone in person or online to submit through the virtual event platform and the mobile app any questions, any observations you have while the panelists are speaking. If you don't want to struggle with a virtual event platform or a mobile app, you're also most welcome during the Q&A to come forward. We have 2 mics in the room, so please just feel free to put up your hands, come forward, and make your interventions through the 2 respective mics in this room. Okay, so I think we can start with our panel discussion. The first question is to Kun Panapa, and I'd like to ask Kun Panapa, what are the Bangkok Principles? Kun Panapa is from Thailand. What are the Bangkok Principles about? And how can the disaster management community use them to support the health community to enhance disaster resilience?
Thank you so much. It's actually, it's Bangkok Principle. Of course, it was originated in Bangkok. We, adopted Sendai framework back in 2015. And the next year, our Ministry of Public Health, who is very active in, a lot of things, and they start to having this meeting with the high-level meetings, and then it's come out with the, disaster risk reduction need to consider the health aspect as well. So there are actually 7, I would say, recommendations or principle in the Bangkok Principle, which are focused mostly on the integration of different or multi-sectoral collaboration in disaster risk management and enhance the health knowledge, enhance of the health infrastructure, the synergy, and also the education of the health worker in disaster risk reduction. Because a lot of time, now disaster doesn't really indicate themselves, oh, hi, I'm an earthquake, hi, I'm this, I'm that, but, it's also multi-hazard. It's also to have more complexity, with also exacerbated by climate change. So pandemic is now becoming one of the most important disasters that we have to deal with, seeing from the example from COVID-19 that we are facing in the past 2 years. And now with that, it's not only they need to know, the health sector doesn't not only need to have their own health education, but they also need to learn how to prevent and reduce risk that will happen after the pandemics, or that will prevent, risk after the big disaster happen and happen to have the pandemic right after the disaster. A lot of time, when you have the multi-hazard event happen, there could be an event that the factory exploded and all the material, the chemicals leak into the public, and that could cause a health hazard. So all the health workers need to know how to reduce those risks, and also how to work together with disaster management agency. So how we did it in Thailand is that, we indicated the pandemic and health sector is one of the most important part in our disaster management organization. We have the National Committee on Disaster Management, which incorporated 23 line ministries involved in disaster management, including the Health Ministry. During the COVID-19, we work hand in hand together with the policy that provided us from the policy level. The Prime Minister, they set up the COVID Center, National COVID Center Management. And us, as the disaster manager, has to support and work together with the Ministry of Public Health, who's the one knowing all the technical, knowing all the measures that would need to be implemented down into the local level. For disaster manager, we would implement those policy and measures through our network of local agency, local organization, and our other DRR network. So I think, nowadays, health and disaster risk reduction needs to go hand in hand, and we need to work under the same policy, the same framework, and same SOP.
Thank you so much, Kun Panapa, for sharing with us your direct experience and for underlining the need for an integrated approach, and with it comes the policy coherence. And this is really at the heart of the Bangkok Principles. So let me maybe open the floor for any observations. Anyone who would like to make an intervention at this point? You will also have an opportunity to ask any panelist after all three panelists have spoken. You will have an opportunity to raise further questions. But, interestingly, the health aspects came into the Sendai framework, a number of years before anyone could have imagined a pandemic of the kind we've just been through. And likewise, the Bangkok Principles were negotiated and agreed to in 2016, also well before anyone could have imagined the pandemic.
And it's very interesting that our health sector pick up right away. Of course, they are full of doctors, smart doctors, so they pick up right away. They're trying to, actually, they were working together with us and asking for the disaster manager like us to provide them with how we manage our EOC, what are the systems that we are using. So to have the same understanding of disaster management and disaster response, also as the health aspect into it, is very crucial, that we speak the same language. We integrated our work together to minimize the risk of our society.
Absolutely, and that same language is so important. And that brings me perhaps to the second question. And I'd like to pose the second question to our second panelist, Professor Emily Chan. And it's, really taking up this issue of same language, because we know it's not easy. There tend to be silos. And so how can disaster management and health communities work together and break down these silos? And we've seen them being exposed by the COVID-19 pandemic. So really, how could we better prepare and address this future integration of the two sectors? So over to you.
Okay.
Professor Chan?
Thank you. First, let me start with, can you hear me clearly?
We can hear you well.
Okay. Thank you very much. Very glad to meet everyone online. And I know there it's a time gap, but I try my best to speak very slowly. Okay. As you rightly point out, and Panapa has also pointed out the importance of working together with pandemic. I wish to highlight several things. The first important description is that the needs of multidisciplinary collaboration has always been in discussion. However, due to different institutional system and required disciplinary outcomes and targets, health and other sectors has always been working in silos. But I will argue that the pandemic has actually offered a chance for us to revisit what and how things can be done to support the response community. And I want to point out particular about two additional dimensions to rethink, with this multi-collaboration needs and what are the latest discussions, at least in the health sector. As a start, the prolonged and protracted nature of COVID-19 urge us to revisit the assumptions that events and incidents are happening independently. During the past 30 months, there are repeated new waves of COVID episodes that coincide in many communities with extreme disasters such as cold spell, heat wave, typhoon, and earthquakes. And in my home community, Hong Kong, when we were hit with the fifth wave, with Omicron, it coincided with a cold spell. Hong Kong is a subtropical community which rarely affected by cold in that extreme form. But it also, once again, repeatedly showed us that disasters are increasingly simultaneous and even cascading in nature with climate change. And that is a wake-up call for many communities, especially highlight the importance of all hazards, health risk-based approach in planning. So it can be many different types of disaster, but the health risk is something that we focus on so that the health people can prepare the health system and also gives us a common terminology with the non-health sector of where we may go forward with our life-saving or protecting community approaches. And from the research perspective, WHO has advocated for the health emergency disaster risk management. We call it health EDRM, research paradigm, since 2019. On the policy side, to support the implementation of the Sendai framework and also the Bangkok Principles. But from a broader scheme of discussion is to hope to offer a global research collaborative platform to encourage and enhance research partnerships, to both identify health evidence, to support cost-effective disaster risk preparedness planning and response efforts. It's not only for the health community, however. It will be important also for the health people to also inform the wider non-health communities about such research evidence and such information is available. So that would be a need or a constant need of bilateral communications or even multilateral communications between the health sector and the other sectors about the findings we managed to gather from the health side. But we will also need the non-health sector to tell us, the health people, what may be needed to be researched upon. Otherwise, it would be like a parallel track of two groups that with the same intention, but they never meet. And as our moderators kindly point out, with some case example, it's important that I point out two quick examples as well. That COVID-19 managed to offer us again a multidisciplinary angle or needs, to protect community. With the volume of care need for COVID-19, there's a global outcry to inform the better home care patient management practice. again, things has always been going on in the community, but with COVID, with the overwhelming need that in many communities affect the secondary and tertiary healthcare provision, people now turn back to primary care system to enhance self-care and major updated of guidelines, network formation, and community empowerment for self-care. I would definitely encourage everyone to go on the website of WHO to look for the home care guidelines. The reason for that is not because just for their health. It will be clearly highlight that in order to make it work, it's not just the patient or the self-care. We need the system to support resources, infrastructure, material delivery, and even to maintain the basic healthcare or lifeline infrastructure to support the needs in the community. And most important of all those living alone and with limited support, for supporting their own well-being. And it's not only in the community level. Another very important example for the policy side, at the system side, because of COVID, many communities actually have upgraded their diagnostic and laboratory facilities for the coronavirus. But those facilities is not only limited to COVID or even influenza. The system is there, the risk communication facilities are there. And it would be important for us to think about how we can expand the use of such system to cover other important global climate disaster risk, such as vector-borne diseases. There are plenty in the region, malaria and dengue. So I will urge, in view of the limited time, that the COVID pandemic should not only improve facilities to only detect COVID. It should make use of these valuable resources to cover other infectious disease control and prevention needs. And to make this work, it's not just the health sector. It has to be multidisciplinary and with the support of other areas that are relevant to disaster risk reduction. So thank you very much.
Thank you very much, Professor Chan, for sharing with us your valuable insights from your very wide experience and in-depth knowledge. And the protracted nature of COVID-19, as you said, really made us all rethink many things. And it was good to hear from you about some of the things that have started to improve as a result of COVID-19. And in particular, the re-emphasis on primary healthcare, self-care, home care. So this, I think, is one of the important, sort of maybe going back to how it used to be. A lot more emphasis was on secondary and tertiary healthcare in the more recent past, but now we are going back to basics, given that the pandemic hit almost everyone. The diagnostic laboratory facilities as well, the upgrading, and then you placed a lot of emphasis on the need for us continuing to improve our systems and taking the multidisciplinary, the multi-hazard perspectives into account. And then also the emphasis you put on life-saving, and that is really where the disaster risk reduction and the health sector really have one fundamental common objective. It's to save lives. And that should be, I think, an inspiration for cutting across the silos and working together. So let me open it up for any questions or any observations at this point. If I see none, perhaps then let's move on to our third panelist. And our third panelist is from, sorry, my pages are stuck, is from Timor-Leste, and medical practitioner, orthopedic doctor. So I'd like you, from your experience, I'd like you to tell us about how a small country, a newly independent country like Timor-Leste, has managed to actually operationalize the Bangkok Principles, and how you have managed to integrate emergency and disaster risk considerations into your national and subnational strategies. I think your experience could be very interesting for many other small island developing states that find themselves in similar situations. Thank you.
Thank you, Ms. Bonapace. And thank you for the opportunity for me to share about what is Timor-Leste status in terms of implementation Bangkok Principle. Let me start with introduce about Timor-Leste with 1,300 populations. It's a small islands between two countries, Australia and Indonesia, with cross-border to West Timor. Timor has 13 municipalities. And then 30% of the population is in urban area and 70% is in a rural area. Geographically, Timor-Leste is exposed to multiple natural hazards, which include frequent events such as tropical cyclone and riverine flooding, drought, and also landslides. About the health systems, the Timor-Leste public health system itself is decentralized. We have primary, secondary, and tertiary care. Primary health care provides care through the network health posts, community health posts, and also we have integrated community health service. And secondary health care is running by the referral hospital. In the 13 municipalities that we have, there is 5 referral hospitals. And tertiary health care is we call also as a top referral in the country. It's located in the Dili, in the national hospitals. Regarding Bangkok Principle implementation of health aspect of Sendai framework for disaster risk reduction in Timor-Leste context, and as our first speaker just mentioned about there is a 7 principle, and also each principle have key actions. So what I'm going to explain what we have done and what we are going to plan. In the first principle, the government of Timor lead the development of the national action plan for health security, which includes action for strengthening care capacity for implementations and international health regulations. This technical area is focused on national capacity to detect and respond to the biological hazards, which part of the all hazards multi-sectoral plan. And then the second principle what Timor-Leste has done is development of the essential service package for primary, secondary, and tertiary care, which have a strong component of critical emergency and trauma care against man-made and natural disaster and emergencies. We do also have a training to the referral hospital for basic emergency, and also we bring to the level of the community health service. Emergency care system is strengthening into the referral hospital, as well as in the last 2 years, we also stabilized ICU in the 5 referral hospitals with equipment, medicines, consumable procured to make them functions. COVID-19 has further brought to fore this aspect, more coordinated approach between health services, administrative group, and organograms being revisited and revitalized for ensuring adequate coordinations between nationals and grassroots level facility. How about the third principles? A detailed assessment of emergency care systems taken in the last year for 5 referral hospitals, and based on that assessment, reports planning and implementation towards making these units function by the referral hospitals. Long-term training planning being planned in country currently as next phase of developing advanced training capacity with the country and becoming self-reliant. A detailed infection prevention control, patient safety and quality analysis was also done last year along with the same basic idea of keeping patient safety as core principle and enhancing quality care in health units. This will help in goal sustainable health units. For principle, what we have done, training during ICU and emergency medicines, includes approach to emergency, including mass casualty incidents and principle of the triage. For the fifth principle, there is the joint external evaluation conducted in 2018 made an initial assessment of biological hazards and zoonotic disease as well as chemical and radiation hazards. Overall, there was a limited understanding and capacity to take this risk, but efforts are being made to be prepared for them. The sixth principle, the risk communication and community engagement has been important part of for outbreak and emergency preparedness and responses. Training have been organized and actions plans have been developed in the area, including using innovative communication approach and early warning message. The other point is important here is cross-border coordination meeting having conducted regularly with Indonesia, with mechanisms stabilized to manage communicable disease, including surveillance, information, and sharing. Unfortunately, this cross-border meeting for the last 2 years is not run well because of the pandemic. And the last principle, the government Timor-Leste early of this year has stabilized a civil protection authority, is the national executive body that regulates a civil protection activity. And from our part, from Minister of Health, we also stabilized the autonomous institution for ambulance and emergency service. The aim of this institution is to more specific and more focused, so what we want plan in the national can reach the grassroots level. So I think that's what Timor-Leste has done regarding the implementation of the Bangkok Principles. As I mentioned before, we have several key actions that we have already done, but few that we need to plan to execute the plan. I think that's all for me, and there is a question I'm happy to answer. Thank you.
Thank you very much, Dr. De Silva, for sharing with us your country experience and an impressive list of very concrete activities that you have undertaken in implementation of the Bangkok Principles. So thank you very much for sharing with us those very useful examples. So let me open the floor in case anyone, yes, please. Could you kindly introduce yourself before you?
Yeah, okay. This is Ramesh from India. Basically, I want to know more about what's the Sendai framework. And you can see in the para 30I, that's the one thing is that it was decided that we'll promote and supporting and promoting the local health worker about the disaster medicine. So if you have done in such manner, so we want to learn the how and what have you done regarding the disaster medicine, especially for the grassroots community health worker. So
thank you very much. Is there a panelist that you would like to direct the question to? It's open. Okay. Okay, so let me open it up to our 3 distinguished panelists. If anyone would like to answer the question related to community level and disaster medicine.
Thank you. Let me share about the experience for Timor-Leste. Since we have the autonomy of the ambulance and emergency services, one of the units we work about the emergency and disaster. And this unit or department, as I mentioned, we conducted the training from the national level, and we do the TUT, and then the training continued until to the community health level. And then that's what we are doing in Timor context. So, because as Timor is not like India, it's huge, Timor is small, but the way that we treat, or the way that we encourage our community to involve is quite successful. Yeah.
Well, as for Thailand, I would say the volunteer and community worker were actually the key point, the key entrance to Bangkok Principles. And during the COVID-19, they were working so hard and actively, and they are the one who's reduced the number of the people who infected with COVID-19. In Thailand, we have village health volunteer. And those are the people at the community level that were trained in basic community health practices. They can do first response for help, of course, and some of them were also trained in disaster response. So those are two combinations that we start at the grassroots, at the community. We not only have those programs, it's also in our act. You know, those volunteers get compensated. You know, they get recognition, they get social recognition at the higher level as well. So, you know, in building a strong volunteer, not only a system that we need, we also need to have the social rewards. They need to be recognized because they are such a crucial part in driving the disaster risk management and the health, especially in the health sector.
And then maybe I can add another thing that experience from Timor during the COVID is the volunteer is not coming from the government itself, but also from the other partners and also other society like our Red Cross and also partners. Is very, very useful because during COVID, the Timor context is human resource, everything is really limited. But with the communication and coordination with the partners and the others, multi-sectoral is very, very useful for us, and then we can overpass the situation. Yeah.
Please.
Right. Okay.
Please.
Because as per, we have been focusing on the three level, primary, secondary, and tertiary. So at the community level, suppose in the rural community and indigenous community, so the health system in some country, we can see that the health system is the fully modern medicine is the primary healthcare services. But what's the link of our indigenous health system, our traditional health system? So how we can promote through the community health worker? Because most of in the rural area, they are not literate, they have not much exposure. So how we can contribute to enhance the capacity for our community health worker in the field of disaster risk reduction?
Yeah.
Right. Can I?
Yes, please, Professor Chan. Please go ahead.
Yes. Hi. Yes. I thank you very much. I think the question Mr. Ramesh has been asking, it's very important. In fact, some quick experience to share. It doesn't take a rural community, even in an urban-based community like Hong Kong, during the pandemic, because in the city, they practice, at least we practice, complementary medical system. So, of course, the medical care has an overwhelming reliance on the Western medical practice. But once the outbreak or the pandemic reaches a certain level, it becomes a community care responsibility. And in the community, many things happened. We know that the treatment is not available for people unless they are very severely affected in the hospital. So there are many ongoing practice in the community using traditional Chinese medicine. Some of them are well researched, at least by the research community in mainland China. We have evidence, we have the dosage use of medicine. So it's a matter of choice, and it's a matter of confidence of the practitioner to deliver the medicine. But there are also a number of ongoing, we call it recipe, that it was well meant to treat patients, but it was never confirmed scientifically. So, I mean, you pose a very important question in communities where traditional practice is available, and many of the times, very important, how can our system support or empower community care? And I think that also brings us back to another questions online I can see related risk communication. Aside from the scientific aspect, need to clarify to protect community so that the treatment is relevant. And that's why the research upon clinical use will be important, at least even practical research, not just from the laboratory, to see how patients responding, to share with the community what's happened for people using certain drugs, and giving certain warning to the community about drug side effects. But also, I think a constant open communication, what's going on, and report to the community about misinformation, disinformation will be important. Personally, I mean, in extreme events, I would argue that any resources, well-meant efforts should be respected. But it does take institutions, civil society groups to clarify the accuracy of the information. And from the system perspective, my two other speakers also highlighted a lot of the high-risk individuals are those who are working in the front line, volunteers. How do we protect them? Because they are actually with extra risk of infecting with pandemic. So, I mean, those are all issues which are relevant, especially in places where traditional medicine is also respected and being practiced. We need the research to support it, we need a policy, and we need the information platform for it. It coincides with the whole argument about WHO saying that health emergency disaster risk management needs of information and research.
Thank you.
Thank you.
Thank you very much to both our speaker from the floor and Professor Chan and the other panelists who answered. So I think a very, very interesting topic. Clearly a topic where open communications, information, more evidence-based research is needed. And at the end of the day, it's really about building the trust between the communities and the practitioners and the volunteers. And so trust is really that underlying value that can help mitigate the worst of crises. Okay, so I think we can move on. And now we're going to sort of take a jump from the community level. We're going to jump into the regional level. And perhaps, you know, the next presentation is going to present a risk and resilience portal. This is an Escap initiative. I'm with Escap, UN Escap in Bangkok. And this risk and resilience portal has been developed to enhance the evidence base, as we were talking about in the previous intervention, in terms of the cascading nature of hazards and disasters and crises, and their compounding impacts, and how this dynamism that goes on between these different crises affects risk profiles and climate adaptation profiles of countries. So I'd like to ask my colleague, Dr. Madhurima Sarkar-Swicegood, to present to us the portal. Over to you, Madhu.
Good afternoon. Am I audible?
We can hear you well, Madhu.
Fantastic. Thank you, Madam Moderator, and Good afternoon, esteemed panelists, participants, and truly thank you for allowing me the opportunity to briefly present the Escap Risk and Resilience Portal, which we launched in 2021 in order to support the operationalization of the Bangkok Principles. Can I have the next slide, please? So the portal can help operationalize the 7 measures laid out in the Bangkok Principles, as you see here, which include incorporating things like disaster-related mortality and morbidity into multi-hazard early warning systems, promoting systematic integration of health into disaster risk reduction, and supporting information sharing and science and technology for all hazards, including biological hazards. Next slide, please. So the portal really does this through understanding risk and resilience from the lens of a nexus approach that integrates disaster, climate, and health analytics together. As has been seen from the panel discussion, that the convergence of COVID-19 with natural hazards show a much more complex convergence of risks. But not just COVID-19, there are many biological hazards, as Dr. Chan said, that intersect with natural hazards, including water and vector-borne diseases that increase with flooding, malnutrition that increases with drought, mortality and morbidity that increases with heat waves and tropical cyclones. The most recent IPCC AR6 models note that under climate change and warming, every additional 0.5 degree increase in warming amplifies the intensity and frequency of heat waves, heavy precipitation, and drought. Next slide, please. So through the portal, Escap offers technical support to first understand the combined risks of combined risk hotspots of natural and biological hazards that are under various climate change scenarios, estimates the combined losses from natural and biological hazards, and estimates the cost and priority of adaptation to mitigate the impact of this disaster, climate, and health nexus. Next slide, please. So as you see here in this slide, first, the portal has developed location-based GIS analytics to show where the most exposed populations are and will be to both natural and biological hazards under a current and 2 climate change scenarios. So as you can see here, under climate change, there are areas of emerging and intensifying risks. Here you see an example of floods, and we see that populations in South and Southeast Asia will be the highest affected from floods and flood-related biological hazards like dengue, malaria, and other vector-borne diseases. Next slide, please.
Madhu, sorry for interrupting, but I will need to ask you to please conclude because we're running out of time and I still have questions that need to be answered from the floor.
Sure. Sure. If I can get 1 more minute, I will quickly wrap up.
Yeah, please.
So we've also developed GIS-based analytics to showcase where health infrastructure is going to be exposed. And I think one of the things that the panelists also mentioned was looking at the most vulnerable people and which health, how the health infrastructure that supports them. Next slide, please. And as you can see here, we've also estimated the annual losses from natural and biological hazards for all countries in the Asia Pacific. The current combined annual losses from natural and biological hazards are around 780 billion, with an increase to about 1.8 trillion under the worst climate change scenario. Next slide, please.
Okay, Madhu, very sorry, but I need to stop you here. So thank you very much for sharing with us and giving everyone a flavor of what's available on the Risk and Resilience portal. And I'd like to encourage everyone to visit the portal. And we at Escap would very much welcome your feedback. And we would, in particular, welcome feedback from health specialists and practitioners who work who work in the health sector, so that we can continue to strengthen those interlinkages and coherence between the two sectors. So I have a question that has reached me through this very nice iPad. And the question is whether it's posed to any of the panelists, whether you could speak to best practice for managing a response to major heat waves. I think, this is our new normal now, these big heat waves that hit us. And they're very challenging. They're challenging for the management of energy, for the impact they have on infrastructure, but especially for the impact they have on people and vulnerable people, the young, the elderly, those that are not in good health. So if anyone would like to take that up, please feel free to just jump in.
I think for me, for Thailand, I think it's one of the things that we're doing very well is, we have the application that, people can send in asking for help, during the disaster with location that they are in. And, with the new technology that incorporate a participatory approach, that people can reach out to the service of the government or service of the community would be really helpful. So I would say that, to have the standard emergency operation procedure and communication, as well as a dashboard. I think I went to the marketplace, and you guys here have a very excellent dashboard that the local community can send in the information right away. So the fastest you receive the information, the faster the help can get to the people. So technology, I think that would be one of the key points that would help.
From Timor-Leste, context is what we are using is early detection and then do the screening. So, but regarding the technology, we are not advanced like Thailand, but the most valuable information is from the community and from person to person. But again, what we are from MOH, that if there are early detection, is still a high alert for everyone's, for anything. And then if there is evidence, then we will do the screening for that.
Thank you. Thank you very much to both of you for sharing those country experiences. And Professor Chan, if you are online, if you would like to share anything from your perspective.
Yes. Thank you. I want to share from, what we find in research for heat wave warning. In Hong Kong, we do have a very interesting city with risk that was compounded by how we build our buildings. We call it the heat island effect. So incidentally, if there is a day of 36 degrees Celsius in southern parts of the city, individual will experience as high as 39 because of how our housing heat was trapped. What we found, which is probably worth rethinking about how we do heat wave warning at the institutional level, we did surveys to ask our community, because it's a city, information are quite disseminated, that have you heard about the heat wave warning? And we realized that because of the highly infiltrated with TV, radio, and with internet, people actually, 98% of our sample, which is quite representation of the whole community, actually have heard about the warning. The challenge, however, is individual risk understanding. As a case in point, elderly, in the community, because of the heat wave warning, many of them actually choose not to take physical activities outdoors, which you can imagine is a logical choice because it's out there, it's hot and it's humid. But as it turns out, because of how our city was built, the indoor temperature could be higher than outdoors. But individuals simply assume that, okay, there's a heat wave, I'm not doing anything so that to reduce my risk. It's actually worse if you don't specifically bring the risk back to the individual level. So I think that is another layer of risk education that should be done in normal times. Because when major event hits, the whole system would have to respond. But sometimes we cannot just assume our community understand the health risk literacy. And I think that aside from the health sector needs to clarify with the fact and clarify the pattern, it would take out the wider community, the media communications, education system to support the community, perhaps to put together teams of young people as volunteers to check out on their neighbors and community networks. And there are many examples of such. I understand we don't have enough time, but I think that is something important. So warning is one level. Community health risk literacy is another very important level, which we need community actions and multidisciplinary actors again. Thank you.
Well, thank you very much to our three panelists for sharing with us quite diverse experiences and quite diverse responses. And clearly, there are rural challenges, but there are also urban challenges. And in terms of the challenges that Professor Chan was explaining to us, that's when we go back to that primary care and self-care emphasis, in that, self-care during heat waves might save lives if people actually know how to protect themselves. And staying indoors, unfortunately, may not be the best solution, but there are also ways to enhance that personal resilience, if the knowledge is there, if the information has been shared. I see one more question from the floor, please. If you could kindly introduce yourself.
Thank you. Yes. My name is Liz Mcleod. I'm a surgeon from Melbourne. I'm currently working with WHO on surgical systems in the Western Pacific. It's more of a comment, really, than a question. It's just that given that 4 out of the 7 goals of the Sendai framework make explicit reference to health, I'm just dismayed that we've got one session in this forum on health and we're kind of parked as a backwater at 5 p.m. And as a surgeon, I'm not only interested in the surge capacity and trauma response for sudden onset disasters, but we've seen with the pandemic how critical strong health systems are, as they're foundational for resilience of people. And so I would really like in this forum and others to see health raised as a much broader discussion. We've had a lot of discussion the last 2 days about infrastructure, a lot of talk about concrete. And I would put to you that healthcare workers can work without infrastructure, but infrastructure can't work without people. So I think we need to really elevate the discussion around health.
Thank you very much for that contribution, very important comment. And I think in the room we share that sentiment, and we are all part of the group of converted, and we will continue to do our best. And from my perspective, from the Escap perspective, we have given high priority to this operationalization of the Bangkok Principles. And we will continue to do our best, and we do look forward to partnership with WHO and with other UN agencies and other countries. Please, you have the floor.
Thank you. Good afternoon, everyone. My name is Bray. I come from Hong Kong Red Cross, the branch of the Chinese Red Cross. First of all, I would like to share my experience in the community resilience. When we conduct a series of projects, especially the disaster risk reduction projects in the community, even though before the COVID-19, the pandemic, we also emphasize the health factor in the community. So we provide a lot of health-related education to the community. And then when the COVID-19 happened, we found that the knowledge is very, very important, and the knowledge saves saving the lives. And also, before the COVID-19, we support the community to establish the community's own self-assistance group, community-based self-service group. That means when disaster happens in the community, they can help themselves, each other. So my question is that for the community-based group, for higher level strategy or the policy making, is there any recommendations or ideas to keep the group sustainability to exist and keep their passions? Because we all think the community group is their own assets, and they are the first responder to their own community. That's all. Thank you.
Thank you. Thank you very much for that contribution and an important question.
Yes.
So let me hand it over to our panelists once again.
So I think, as I already mentioned before, that in Thailand, the village health volunteer was actually established by one of our princes 40 years ago. So it was a visionary project. And you know, one thing that they keep going is because they're very passionate about taking care of their own community. So we must really give social recognitions, also, you know, give them incentive in driving that. And it doesn't have to come from the government, you know, it's come from the Red Cross, come from NGO, or even community volunteers. So I think, you know, in Thailand, you know, the culture of volunteerism is really big. So I think that's one thing that keep it going, building the culture of volunteerism, giving back to the community and give them social recognitions. I think that's one thing that will keep them going. Thank you.
Thank you.
Professor Chan, would you have any comments?
I think what our questions, that question highlight the importance, again, back to general education to the community, the importance of their stakeholders. And they're actually a part of the solution too. So definitely, as Amy has just highlighted, the importance of volunteerism in the community.
Okay, thank you. Thank you very much. We're running 5 minutes over the time, but I cannot help but give the floor to our last person to ask a question. I wish we actually had more time, because I think the discussion is really fascinating. So I cannot help it but give you the floor.
Thank you very much. And, so I'm Jonathan Abrahams. I work at the Monash University Disaster Resilience Initiative. And I thank UN Escap and also UNDRR for actually putting this particular session on, but I also concur with the comments that have been made that we actually have to have a much stronger profile for public health in this Asia-Pacific Ministerial Conference in future. And collectively, let's work out how we can do that. One thing I want to say is, of course, we've just come out of, or we're in the middle of COVID-19, we're emerging from it. And it's still really important to look at how the disaster risk reduction community is going to address biological hazards. And arguably there should be actually a session here at this conference, given the proximity of COVID-19 around the biological risks. I know that people come to these conferences for resources as well. So one of the things I'd like to point to is that WHO has got a lot of resources that you can point to, that you can use to manage these risks. And also, if you want to be part of the WHO Health Emergency and Disaster Risk Management Network, please go to the website. It's an open network, and anybody who wants to be participating in that effort to strengthen the evidence base for how we manage risks more effectively, then please register with that. And just finally, people who work in the health sector are really strong allies. They're people who are extremely passionate and committed to people's health and well-being. And so anybody who's actually working in other sectors, please involve the health sector in what you're doing, and it will certainly serve the people whom we're all trying to serve together. Thanks.
Thank you very much for that very generous intervention. And I think on that positive note, it's a good way to end our discussion together today. But before we close, let me, on the part of Escap, UN Escap, commit to taking this work forward, to elevating the importance of this work, and to dedicating the small amount of resources we have, but to dedicating resources to this initiative. I think it's an extremely important area that we need to continue to work on. We know that there are going to be more disasters. We know that there are going to be more pandemics. Hopefully epidemics, not pandemics, but who's to say? And preparedness is the key. And preparedness by working together, multi-sectoral, multi-stakeholder, we can build the resilience. So you have Escap's commitment, and I'm sure, as we heard, the commitment of many other UN agencies and many other ministries, health sectors, disaster specialists. I think we're in this together, and we share that common passion of trying our best, saving lives, and improving human well-being. So let me end now before somebody comes to throw me off the stage. And I'd just like to end by thanking our three distinguished panelists very sincerely for the wealth of experience and knowledge you have shared with us today. I'd like to thank my colleague Madhu for presenting the Risk and Resilience Portal. And then thank you very much for being a very active and inspiring group of participants. As always, I learn a lot from moderating sessions and participating, so thank you very much. And then finally to Iria from UNDRR and to Troy from the Government of Australia, very special thanks, and to all your respective teams for having organized this session and for all the facilitation and support. And that includes the technicians who have enabled us to connect in a very convenient and seamless way. So really appreciate everybody's contribution to this session. Thank you, and see you again.